Hi all, good afternoon. Thanks for joining for our second episode of Let's Talk It Now live series. I'm gonna give it a few seconds for everyone to join in while I go ahead and pin this comment. In the meantime, if you're joining in, let us know where you're coming from, where you're joining from. Go ahead and leave a comment. So for those of you who are new here, I'm Veronica, social media manager of Nao Medical, and I'm so honored to be moderating these super important conversations that we have on our live series. This week is Suicide Prevention Week, so today's topic will be suicide prevention awareness with Kwame Okyere-Amofah, who's actually fairly new to the Nao Medical family, so we're so happy to be welcoming him in, as well as Keeley Teemsma, who's the founder of Refresh Psychotherapy in NYC. Mental health is a super important topic and it should be taken very seriously. The World Health Organization actually estimates that 90% of all suicide victims have some kind of mental health condition. And that's why at Nao Medical we prioritize an inclusive and compassionate approach to help you on your mental health journey. We created a healthcare journey that's personalized just for you, and it takes the weight off your shoulders from booking appointments and following up on your appointments. So we'll be touching more on this healthcare journey soon, but if you're ready to create your own personalized healthcare plan and mental health journey, go ahead and click the link in our bio where you can learn more and get started. So now without further ado, we're going to give a warm welcome to two experts in the field, Kwame and Keeley. So let me just get them in here. All right. Hi, Keeley. How are you?
How are you?
Good. Thank you for joining. Kwame, I see you're there. All you have to do is click the little video with the plus sign at the bottom so I can let you in. All right.
Hello,
Great.
how you doing?
How are you? Thanks for joining as well. I'm super excited for this conversation.
It's nice to see you both again. And Kwame,
Thank you.
I told you
Yes,
the
yes.
time we met, love the bow tie.
Thank you, appreciate it. Thank you, thank
Yep.
you. You,
Agreed.
you both ladies are looking great.
Thank
Thank you.
you.
Thank you.
So I'm going to pass the mic off to both of you so you can start by introducing yourself. I'll start with you, Kwame.
Oh, so ladies first, but my name is Kwame Okyere-Amofah. I'm the Psych NP for Nao Medical. We have a mental health practice now as part of the integrative care. I'm fairly new here, but I've been in mental health treatment and service for the past 18 years, and I'm excited to be here. I do everything from psychotherapy, medication management, psychiatric evaluations, crisis prevention and intervention, and I'm open to see patient, clients, co-workers. I'm open to everybody, and I'm hoping that by the end of this presentation, we're going to have a very direct and in-depth knowledge of suicide prevention awareness and some measures that we can do. Thank you.
Thank you.
Thank you.
Go ahead, Keeley.
So I'm Keeley Teemsma. I am, as I said, the CEO and founder of Refresh Psychotherapy. We are in South Slope, Brooklyn, as well as the financial district. About 40 clinicians on staff. You can connect with all of these people. We're the most diverse practice in the city. So that's awesome. I've been a psychotherapist, a licensed clinical social worker by profession for about 14 years. I've been doing math correctly in my head. Maybe not. And my specialty is working with adults. I work a lot on anxiety, perfectionism, as well as women's health issues such as infertility and looks like my video froze.
Oh,
okay.
technical difficulties. All right. So if you guys have any questions for them, go ahead and let us know in the Q&A box. The little question mark at the bottom, just click that, go ahead and type the question in. In the meantime, we're going to be answering some questions that we received prior to this. So let's get started. So language matters, obviously we know, and talking very direct with people who might be in crisis might not be the best approach. So what are some tips to talk to someone about suicide, and how can we organically bring it up?
I feel like bringing it organically is a very difficult for people. And grad school, our would have us role play after role play, just not even doing it with another person, just being able to say it out loud, asking the question in many, many different ways. Practice that over and over again until it doesn't feel quite as weird.
Mm-hmm.
However, I'm sure most people in their lives are not mental health professionals are not doing that, and that's completely understandable. Why would you? But it is something everyone needs to ask. We know that health and suicide are stigmatized cross-culturally. There is not a culture on this earth that has not stigmatized mental health. It's getting better in many cultures, but we are all united. It's how to talk about health. So honestly, advice is doing my grad school advice. Start asking the question over again. Like, are you thinking of hurting yourself? Are you seriously thinking about yourself? Do you have a plan? Things like that.
Thank you. And another thing that when people say ask directly, it has two folds to it. So one thing that we have to remember is that suicide as a topic, suicide as a disease in itself, it's very complex, right? So one size might not fit all. The key thing is what Teemsma said. Ms. Teemsma said it has to do with the fact that you're asking questions, you're probing. And the most important part about asking questions is that you're willing and ready to listen, right? So to put it in a nutshell, people or family members, all walks of life, it cuts across everybody. So if you see a person, then, you know, like I said, show empathy, be willing to listen. Also, just ask people how they're doing, you know, reaching out to family members, you know, talking to them. But most importantly, bring the topic to fore. You know, we shouldn't think that asking people about how they're doing, asking them about questions about suicide is going to let them do something. That's the literature states the otherwise, right? If we talk to people, we ask them how they're doing. Have you been overwhelmed in your life? Is there a way that the stress in your life has made you feel like it's too much, right? And when you ask these questions, I think that the person might open up and say, you know, what is going on with your life? You know, and just be willing to listen. So I think that's one of the most important things.
Yeah, definitely. So the next one, what are the main risk factors that contribute to suicide?
Ooh, I feel like there's so many.
Yeah.
Untreated mental illness, for sure. Usually untreated depression, what I've seen. Having a lack of a support system. So maybe you live here in New York, but your family's in some other state and they're all there and you don't have friends here. That could definitely be part of it. Stress, for sure. Stress with anxiety mixed. Someone who worries too far of like, okay, if I don't do this one thing, I'm going to lose my job. And that's enough, putting enough fear in that. I would even say other areas of bereavement, loss of a relationship, loss of a loved one, loss of a pet. Those are big triggers for people.
Yeah, especially the pet one.
Oh yes, and one of the things that important is the number one, support, because for you for a person to arrive at a point whereby they feel like, they're in some pain, some discomfort, and the only way out is to take their own life, you have to be in a position where you're hopeless, you're helpless, you feel like whatever agony, pain that you're going through, there's no end in sight, right? There's no treatment, there's no support. People, whoever is around you cannot get you, right? So we know that, as from literature, men, so there are about 30,000 successful suicides in America, right? And out of 4 out of 5 are men, and majority then comes in use means of handgun and to end their lives. But we know that at some age, so teens to 25 years, these are like a higher rate. So if you take that, suicide, it's the 12th leading cause of death in America. But when you take a population of 11 to 25, it moves all the way to 4 to 6. So at the end of the day, that this population a higher rate of suicide. And so we know organically, if people have mental illness, like Teemsma said, if and it's both diagnosed and undiagnosed, because people can be walking around and outwardly they might show that they're doing great, but inwardly they've lost hope and they don't have anything. So I would say that we should be mindful that you just need all things to come together to trigger the person. So not finding support, being a solitude life, not feeling like nobody gets you, feeling hopeless about your whatever you're going through. It can be social predicaments, it can be medication. One thing that has also happened is that whenever there is like a celebrity who passed away or something like that, it has triggered some people to kind of seek that outlet. When we have children like teens, to be able to talk to them. For instance, if when relationships doesn't go well, adults might take it well, but teens who are like their first love, and so they might take it as, oh, it's not that somebody breaking up with me, it's like I'm unlovable, or I'm a pain to my family. And these are all things that we should look out for.
Yeah, speaking of being mindful, I was wondering if you can explain some of the risk factors some of the warning signs that contribute to suicide.
It's a hard one, and sometimes it's even difficult for us as clinicians to read. Someone can come in and they can be seemingly normal. They might be sorry, I guess there's construction going on next door. I don't know if you guys can hear that. Someone might be like their typical self. Someone might be in a really great mood and you wouldn't think to ask the question. So it can be confusing even to us sometimes. I mean, sometimes one thing that I have noticed, if someone has had an untreated mental illness for a long time and then they start to get treatment and they start to get better, sometimes they take a look at their life, really analyze what it is. And some people are like, this is what my life has become. And then that fuels the thought suicide. So that could be, a warning sign as well. There's, we see in the movies, someone is already they're feeling relieved, but they're also grieving life in a way. So they're giving precious things to others that may or may not happen.
Yeah.
Okay.
So it's hard.
Okay. Yes, and that goes back to why we say that it's a complex, right? It's a like on a spectrum. So you have people who will come directly and say that I'm tired of this. I don't want to deal with this no more. And there's some people who will be in their shell. We've seen people who have had successful suicide that, like, let's say 5 hours before they were dancing. They went to social events and came back. And I think that the kind of easiest way is that you are always, anything that is ordinary or anything that's regular, you're going to find out. So when I see a client, a patient, what I'm going to ask, and I ask them, has life been very difficult recently? Has there been any recent challenges, right? If you went to bed, do you go to bed sometimes feeling like you don't want to wake up in the morning? Do you feel like, you'd be better off if the world was supposed to end? You give them questions that you go open, so questions that they have to elaborate on it, right? And so you ask them, like Keeley said, if you have somebody who come in and suddenly they're gifting you something that was dear to them, right? The patient will come in and out of the blue, or you have a friend will come in and say, I want you to have this. So then your follow-up question, like I always say, questions and with answers and listening. Why are you giving me this? It's not on occasion or something like that. And then what does it mean to you, right? How do you feel? So if we start asking people how they feel and how things and actions means to them, then they'll be able to, elaborate on it. And this is not typical of people who have already been diagnosed with depression, anxiety. We know that people who have bipolar disorder tends to have like heightened mood of suicidal ideation at a certain time. So they say that to catch a break, you have to catch your breath. So the inclination is going to come at a certain time. If you can break that, you have a chance of treating the patient and directing them to better care.
Awesome. Thank you for that, Kwame. So
No
I
problem.
know that we touched base on this earlier, but I think that it would be best if we go more in depth. But some of the stigmas that affect suicide prevention, what are some of them?
So many.
Yeah, I knew that this would be a very in-depth one here.
I feel like at least once a month I hear from their family doesn't want to go to therapy because if anyone found out, that would bring shame to the family because only crazy people go to therapy, which we know is not true by any means. That's definitely a big one. I think in a lot of cultures, maybe just in humanity in general, people are uncomfortable with emotions, so they're more likely, as probably Kwame or I would say, somatized. People will feel a stomach ache and not they could be experiencing anxiety every day. So a lot of times the friends or family tell that person, like, no, you just have a stomach problem. You need to go to the eye doctor.
Yeah.
Things like that.
And so the question to that is that how do we get stigmatized? We get stigmatized in all forms, right? Because the key thing is that it's okay to ask for help. If we can put one word to suicidal prevention, it's like it's okay to ask for help. So some of our most difficulties in life might come from medical, social, relationships, anything. And no matter where a person is, it's okay to ask for help. It might be shameful to say that I cannot handle this, whether it being social challenges, medical challenges, overall in life, and you feel like, oh, I don't want to be. Some people say I don't want to be a burden on my family because they feel like maybe mental health care is going to be very costly, and so they don't want to ask for help, and they think that it would be better for them to end everything. Some people might be diagnosed with a terminal disease or that causes a lot of pain, and they feel like it's an outlet for them to end all that pain, right? They might be even in relationships that they don't see any light at the end of the tunnel, and so they feel like that. So we get stigmatized because we if we're not discussing it, right, then it becomes that it's kind of closeted, it's kind of hidden.
Yeah.
So yes, like why, and people also say that, oh, why are you talking about suicide? Like maybe you need attention, right?
Yeah.
And so, oh, you're trying to get attention, or you want people to. So if we make it very we have to talk about it, we have to bring it in the fore, we have to bring it in the light, and know that regular people, all people go through ups and downs. But some people, when they go to their downs, it's very hard for them to find alternatives. And so, and with all mental health should be at the forefront of care in general. And I'm not being biased to my profession, but I think that's how we should be doing things.
Yeah. And there's even negative associations with pediatric ER, as an example. You're feeling, go down to CPAP and get an evaluation. But a lot of people think, well, I'm going to be people who are really, really worse off and who are really, really ill, and I don't fit into that, so what could the hospital possibly do for me? Or I don't fit into that, so the hospital's not going to take me, why bother?
Yeah.
So there's a lot of stigma too, just about what we see, because for those of us who have depression and anxiety and are, you know, functioning in life, so to speak, who go to school or go to work, have friends, have a family, those are the people who you're not going to know that they have illness. It's the people, unfortunately, who are often on the subway, who are talking to themselves, you know, and that's what we associate with mental illness. Unfortunately, we associate the extreme and discount all of the other areas in between.
100%. And I remember a few days ago when we actually had a conversation, you did mention something about the stigma against medication.
Absolutely.
Yeah, that was a really powerful point. I think that a lot of people kind of just assume if you take pills, you're a crazy person, and you know, pills are so bad for you, and everybody wants to go the holistic route. But sometimes it is truly needed, and I don't think that there should be any shame if you're taking medication.
No, definitely not. And sometimes I mean, Kwame, you know more. You're a prescriber. I'm not.
Yeah.
Sometimes the combination of the holistic route with the medication can help things go a little bit faster. So we know that there are a lot of transmitters in our gut, and we know that protein really helps build those. So if you're not eating enough protein, if you're someone carb heavy, you might be finding that your medication isn't working quite as well, but making a small dietary change could potentially help with that. So there's no shame in that either.
And with a very critical and important topic that's life, right? Um, I think the goal is to get the best care that you can get, right? Because we know that the fact that you suffer from depression is not your fault. You didn't do nothing wrong. You understand? There are scans that shows that the brain of a person who's very suicidal is different, you know, wired differently. And these are not sometimes even to find therapy helpful, you need that medication to kind of stabilize you. Because imagine, you know, we work around. So imagine, you know, you having thoughts in your head with, you know, very degrading thoughts or telling you that, oh, you're not good, you're good for nothing, you're better off not being here, and it's being compounded to you every time. How can you deal with that, right? And so what I tell clients is that think about it. Medication is there to help you, right? Because you can get to a point whereby your basic like coping mechanisms is not there. So you have to up that coping mechanism, and that is what medication sometimes helps you because they kind of cushions you so you can be able to understand and be able to partake in order to know that you are really loved, like people around you really care about you, and then you know that this is not the solution to what you're going through.
100%.
Right.
So, Kwame, I'm pretty sure you touched base on this, especially with men and teens. But are there certain groups of people who have higher rates of suicide? And if so, which ones?
Yeah, so I talked about men because for like I said, 4 out of 5 people who have successful attempts at suicide are men. We have teens, which is very higher. As you know, there's so many medications now that have quote unquote a black label on it. Even with antidepressants, we know that taking those medications in teens might predispose them to have suicidal thoughts. So those populations, I know that the literature says that the elderly who have like no terminal disease diagnosis, they tend to look into be that. And we can talk about celebrities. I think Robin Williams the last time had did that. And so these are the populations that we look for. But it's mostly, you know, it comes in all shapes and forms. We know that single white male have a higher rate of suicide compared to other demographics, right? So we know this thing to be true. So, and then it comes to the same thing which we can talk about, which is that the fact that maybe asking for help is a sign of weakness, and so people don't want to ask for help. So most importantly, these are the populations that we have to really look at them. Even though women tend to have more suicidal ideation, being diagnosed more with depression, men have a higher rate of successful suicide attempts.
Right, right. Kwame, I've been looking online and I haven't really found a peer-reviewed study that I like or that I feel has enough information. Do you happen to know any statistics about the trans community and what their rates look like?
So thank you for asking that question. So we already know that. So the trans gay bisexual community tends to have a higher rate of suicidal ideation compared to the general population. And I mean, you can, when you think of it, it's what we've been talking about, right? There was more. Now we have more acceptance, mainstream. There's more services, because you have to understand that to find a friendly practice to go to, right? Because not only are you dealing with, let's say a person comes to you, they're already dealing with the depression, anxiety, and stuff like that, and then they have to, on top of it, they have to deal with acceptance, right? How the person is going to walk to the office, how they're going to be addressed. There are things that are coming up now about how people have a problem with the pronouns, how to assign people to. So it makes it more complex. And I think that the study is still on, but we definitely know that just by being in some groups kind of makes your chances of suicidal thoughts, ideations higher, because it's compounded just by societal weight and socioeconomic challenges.
Right. And maybe every time if you go to a clinic and you're misgendered, you're likely to want help from the healthcare system because you're already an outsider.
Definitely.
Yeah.
So what are some treatment options and therapies that are available?
Treatment options and therapies. I mean, if there is a diagnosed mental illness, for sure you look into medication. We always support dietary changes, exercising vigorously minutes daily. Those are proven. Those are proven for sure. Getting enough sleep, like basic self-care stuff. If someone really has a ideation plan, really the best thing to do is bring your chances are they're going to go in with the doctor and they're going to tell the doctor, oh no, I have a plan. That's a very, very common thing. But on their radar, then maybe they'll probe deeper if there's a history, if they back their time here. The hospital hopefully can see that record. So kind of building a story with it. Talk therapy certainly helps. I can't say this one more than the others. And some people respond really well to cognitive behavior. Other people do not. They benefit from trauma work or dynamic work where they can the past and reprocess a lot of things. So it's really dependent on the person. It's a little bit of a hard answer. Kwame, you might have more fun.
Okay, so
I do.
Yeah, so I'm gonna go from the basic, the phase what we have, and then I'm gonna go to the more complex one. So like Keeley said, so there's like CBT, other psychotherapy, talk therapy that works, is great. Ultimately, you asking for help, you getting the right diagnosis is very, very important, because I saw that somebody wrote about postpartum depression, which we didn't, which is a major thing. So the treatment of postpartum depression is different from regular depression, because postpartum depression kind of borders on like bipolar disease, right? So we have those that we have to treat them. So you're getting, the right medication that's going to manage your stresses is number one. If somebody is on, if somebody has a diagnosis of schizophrenia, their urge in a commanding auditory hallucination to end their lives is very high, right? And now we know that apart from the regular psychotropics and antipsychotics, which will help with if it's either visual or auditory hallucination, to decrease it so they can partake in therapy is very important. We know one of the medications that are underutilized is clozaril or clozapine. So in studies, clozapine has shown that people with hallucinations, when they are on clozaril, their rates of suicidal ideation, suicidal attempt decreases because all the stimulus, the other stuff get controlled, you know. And then like people who have done like very depressed and they've done like suicidal attempt and stuff like that, mood stabilizers are amazing. You have lithium, which has shown over the years that lithium actually helps people with depression. And also now the key thing is ketamine. Now everybody's singing the praise of ketamine, as in that people who have attempts to, they have had it. So, you know, when it comes to medication, there's no one size fits all. Mm-hmm. We know over studies that some medications helps, right? And then some medications also, if you're on and it help you, if you have anxiety, you know, we don't encourage benzos, but we know that people who have high anxiety and they're also thinking about it's too much to manage, we try to give them, you know, they have benzos and they've had great response to it. So you have, the key thing is get help, go to a professional who's going to help, who's going to treat you, diagnose you the right way, and show you the path, and together you can chart a path that is right for you.
Kwame, do you have any information about those more rare, like transcranial magnetic stimulation or anything like that?
So those are the last the interventions. There are places I know that NY Langone has special treatments for that, even with ketamine, and also I think in the Bronx they also have Montefiore does that. So yeah. Transcranial stimulation. So these things are like, I wouldn't say last minute, but like after the step. If other treatments don't work, now insurance are coming forward and approving these treatments, and some people have had great success stories with it. So don't shoo other treatment modalities. If one doesn't work, you want to up it and see which ones will work best for you. And I don't know if you can put links after, like populations, like if you are the list of places in New York that are like trans friendly, Nao Medical, we're here. We're always open, you know. And then I know Keeley too has like a great practice where you can go to where you are accepted, and that is where you want to start treatment from.
Yeah, everyone's welcome. We get a little dossier that you come in. You'll not be misjudged. You tell us your pronouns beforehand. It's a space for everyone, and that's what it is. When I think needs a mental health provider that they can connect to.
Speaking of, one of the questions in the comments were actually if we have a list of providers in New York that work with trans folks.
There is a directory. I can't think of what it is called. Let me think for a second. Manhattan. It's not specific to the trans population. It's really for lots of different types of communities that aren't quite as like mainstream, so to speak. That's one for sure. There's always the Psychology Today directory. I don't know any therapist in private practice who isn't on it. You can sort by concern and identity, so you can sort and look specifically for providers who are trans affirming. I'm just trying to think if there's a special list, and I can't think of anything beyond Manhattan Alternative. But I do know that there are lots of practices within the city who cater to the LGBTQ plus base for sure.
Okay, so I'm just going to see that list. Yes, you can always, there's always resources that we can put at the end of the presentation, but everybody is welcome to Nao Medical, Psychiatry, Psychotherapy. We're here. We're open to everybody. You'll be accepted. You'll be gender affirmed, and it's a place to start. If you're an employee and you feel like you have to seek help outside, we're open to that. We can give you resources and you can follow through it.
Amazing, thank you. Another question, is it important for my psychiatrist to talk to my therapist if they don't work in the same place?
Right. Yeah, they talk to each other. I mean, it's hard to get schedules to mesh up for sure, but yeah, I mean, if they stay on the same page on what's going on, the goal should be slightly different because they're technically two different providers, technically doing different things, but they. So yeah, you can give your therapist, your psychiatrist information.
Yeah, I can see that being
really,
important.
yeah.
So, and to buttress that point, so therapy, mental health, it's like the another is like a car with a patient, with a patient, the client as a driver, the therapist and the prescriber are all passengers inside, right? So it's good that if we are doing the same thing, we want to share the same goal. It's very important that we keep communication open, right? If I'm adjusting a client, a patient's medication, I want the therapist to also know. The reason is that when challenges come, they can talk about it, right? If they're having difficulties because I'm titrating the medication or it's going up, there's more side effects. So it's very, very important that you have a therapist who is talking to your prescriber. You know, if because I call the therapist, I'll reach out to the therapist and say, hey, you know, this is where we're going. Have you been seeing the same thing I'm seeing? You know, because most of the time you see as a prescriber, you're only going to see me maybe once a month, right? Or twice a month. But most of the time, therapy is like once a week, and you have more time with your therapist. So the therapist can always give a feedback. We can be looking for the same thing. We can have the same goal. So it's very important that there's communication between, you know, the therapist and the prescriber.
That's a great point. Let's see, we have a comment. Kaylee, I really like what you're saying. I want to find a new therapist. Are you seeking people in person? Being home is making me depressed.
We so this is hard to answer. So some of our therapists are taking appointments in person. We are getting a new office lease, which will start in October. So we will have more people in person then. I think a lot of our therapists are going to have hybrid schedules. So they'll have some days virtual and office. So I don't know if that really answered your question. Off the top of my head, I can tell you that for sure that Clark, Catherine, and Bianca are working from the offices. I believe Bianca and Clark have openings. They are both lovely humans. So I'm just gonna, but yeah, as of October, we'll have much more people in the office. We will also have graduate students doing their fellowship here. So they'll be in the office as well, and they'll see sliding scale. So we've got office appointments coming for sure.
Kwame, do you want to speak about
the office? You know,
yeah,
guy.
I can relate. Kwame, do you want to speak about your in-office services?
Yes. So so Nao Medical is now offering psychotherapy, medication management, psychiatric evaluations. We do treatments, and the offices, it depends on where you're located. So we have offices in Queens, Long Island, the Bronx. We are very flexible as far as telepsych is concerned. So if you want to have an inpatient, in-face services, we'll be there where you're located. There's 2 offices in the Bronx, more offices in Queens, and we'll make sure that if you have both, if you want an in-person appointment, you can have it, and if you want telepsych too, we are open and willing to accommodate your schedule.
Awesome. So I think that kind of goes hand in hand with my last question, but I was going to ask, what should I do if I'm in crisis or if I know someone considering suicide? So just basically, what are some resources that we both have and some outside resources?
New York hotline, Long Island has its own crisis hotline. You can certainly call that. You can, is it NYC Well? I feel like the website changed a few times over the last couple of years. I think it's NYC Well. There is a mobile crisis team that can make it out to the person's home within 48 hours. Or you could like, hey, I'm gonna go to the ER with you, and we're just gonna out, and I'll stay with you the entire.
Okay, so the greatest resource that happened and is new in all of it is 988, and that is just for mental. That's just for mental health. So 24 hours a day, you can call that number. There will be a mental health professional at the end of it who is going to talk to you about it. The key thing that I said is that you remember this: to catch a break, you have to, catch your breath. So we know that the intensity and the need to act on a suicidal thoughts is very brief, but it's very intense. you have to ask for help. It's not, you're not a burden. You you'll find help. You just have to ask for help. And when that time, if you can just go through that time, there's a higher chance that you'll find the treatment that you need. So ED, reach out to people, but most importantly, wherever you are, you can even text to 988. So it's a hotline now. Wherever you are located, you can call that hotline. Utilizing emergency rooms is great, and don't always feel that there's a reason why you shouldn't ask for help. So if there's anything you can take from this presentation, is that it's okay to ask for help. Is that it's okay to understand that you have reached a point that the answer might not come from you and you need professional help. And never feel ashamed, never feel weak because you are reaching out for help.
100%. I think that this question that we got in the comments would be a really good ending point. How do we know it's time to step up and talk to the person struggling to avoid doing the act?
How do you know it's time? I mean, trust your gut. That would be my best advice. Trust your gut. If you feel like something's off, talk about it. Not talking about it is what leads to suicide. Be that friend who really asks, who really probes, and that's trusting your gut is really, honestly, advice.
And I'll say over here that don't be empathetic, non-judgmental in your approach, and ask for people. So when I see you today, how you doing? How you feeling? How is life treating you? We should be open to family members. Reach out to them, right? Make it a point to reach out to them and talk about it. The thing is that talking about suicidal prevention does not bring suicidal thoughts to a person who's not thinking about it, right? So talk about it, make it a very a kind of a normal way, right? If we can normalize these conversations, if we can talk to people, then it wouldn't be a problem talking about it. Because if I ask you how you doing every day, how's your life, how's life treating you, are you having difficulties, then it's going to be normal for you. It's been very tough for me, and then you can tell me what it is. So definitely talk about it.
Yeah, 100%. I think that without talking about it, it just adds to the stigma. And I think that it's a very big myth, because I've heard a lot that bringing up the idea of suicide makes them think about it more or possibly attempt.
Yeah, and no, really no.
Yeah. I don't know if you want to answer this question, but there's a question about psilocybin and MDA likely to be in use for suicide thoughts in the next 5 years, and is lithium the gold standard for suicidal thoughts?
I actually couldn't hear part of what you said. Maybe can you just repeat the question?
Psilocybin and MDA likely to be in use for suicidal thoughts in the next 5 years, and is lithium the gold standard for suicidal thoughts?
Okay. Yeah. Okay.
It's 2 questions.
Are there 2 questions? So
yeah.
I mean, lithium typically is the gold standard for treating bipolar disorder. Is it bipolar 1 or 2? Where you have hypomanic episodes rather than full mania. Through suicidal specifically, I can't say.
So, so the answer to that is that, so for mood stabilizers, so one thing you have to understand, lithium is neuroprotective, right? It helps for somebody whose thoughts is being compounded. They're getting lithium, kind of breaks that chain. So lithium has been the go-to medication for that. But like I told you, we cannot say that that is the only thing, because there's some clients who have suicidal thoughts that lithium is not going to do it for them, right? There's some clients who might even be counterproductive to lose lithium. Somebody with this, self-image issues, and they feel better when the lithium, they put on more weight. But lithium is one of the most neuroprotective medications that are great when it comes to mood disorders. And then I told you, if somebody has diagnosis of hallucination, schizophrenia, schizoaffective disorder, schizophreniform. We know that bipolar. We know that Clozaril also is like the standard for preventing suicidal ideations and suicidal attempts.
It is, but Clozaril is a lot of work.
Oh,
a lot of work to monitor.
And that is why. So we know that by the literature, Clozaril is underutilized, and because of that, because as you know, when you start Clozaril, there are a series of labs that you have to go. So you come in, you get weighed, you go to get your ANC checked, you come back, you get the medication, and you have to do that for the weeks. And then as months goes on, it gets stretched. But once a client is stabilized on Clozaril, they do great. They do great. And so if somebody with chronic disease, chronic diagnosis who is struggling, the go-to is Clozaril. Another thing that you have to understand, if somebody takes antipsychotics, 2 of them, and they have no relief, then the literature says that you should then go to Clozaril. So Clozaril is way underutilized in all populations because of the connotation, that is a lot of work.
It is a lot of work, but I think there's also and granted, I won't say when I was in grad school because I feel old, but we were always told, Clozaril is a drug of last resort. So I think a lot of people have sort of been programmed to think that as well. Even us.
Nope, he's frozen. Hopefully we get him back.
Spectrum Wireless, I'll tell you.
Yeah.
It doesn't say it.
Okay, well, in the meantime, thank you so much for taking this time to join us, Keeley.
Yeah,
I truly appreciate it.
Yeah, it was great seeing you guys again. It was great having this discussion, as much of a not happy topic that it is, but glad we had it.
But super important. I think that there were so many gems that allows people to, take mental health and empower them to take their mental health serious and find resources and reach out and kind of just feel seen, more normalized. I think there's just so much stigma, and the word crazy pops up in my head. And I that's just not it.
Yeah.
All right. Well, I don't think Kwame's gonna come back, but that's all right. Thank you so much. Thank you for taking the time. And hopefully we'll keep in contact. I think that we should definitely put out some resources, answer some of these questions more in depth, possibly in a carousel post or something.
Yeah, for sure. And if anyone is interested in checking out our website, it is refreshtherapynyc.com, and you can actually book your appointment online, so you don't even have to talk to anybody, which is awesome.
Yes, 100%. Same here with Nao Medical. If anyone is in need of mental health resources, we do have the healthcare journey, so you can go online. We have a link in our bio and have a concierge help you create your own healthcare plan and get you some mental health resources. All right. Thank you so much. Have a nice night.
You too.
Thank you, everyone, for joining. Bye.